Welcome. My name's Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar about selective eating and EoE. Joining us today is Holly Knotowicz. Holly is a certified speech-language pathologist specializing in feeding assessment and therapy. She provides private and telehealth feeding therapy through her business, Picky Eaters Anonymous. She is also an international speaker and published author on feeding development and dysfunction, including specialized treatment strategies for eosinophilic esophagitis, IgE-mediated food allergies, and FPIES. Welcome, Holly.
Thank you, Jen, and thanks for APFED for having me here today. I'm going to share my screen. I just wanted to start and kind of share a little bit about myself. In case if you guys don't know me, I am a speech pathologist and feeding specialist, and I have been working in this population for over 16 years, and I have EoE myself. And the reason why this is so special to me, this topic, is because I didn't know I had EoE my whole life and was kind of labeled as a maladaptive, picky eater. And then I started my career at Children's Hospital of Colorado, where when I sat in during an evaluation for one of our patients, I was like, this sounds a lot like me. I think I have this. And then lo and behold, it turns out that I had EoE. I have a colleague on here, Catherine Winden, as she participated and helped me create two slides that I thought were really relevant in terms of occupational therapy and sensory regulation that I wanted to share with everyone. All right, so let's get started. The next slide is just a copyright slide, and that I'd ask that there's some patient photos in here, and that if you please do not just reproduce or share this without written permission. So let's talk about our course overview. So we're going to talk about why kids may not eat. I'm going to dive into picky eaters versus APFED versus pediatric feeding disorder and how it relates to EoE. I'm going to share with you guys how to build a positive foundation for meal times. And I'm going to talk about what that might look like, a traditional meal versus a learning meal. And we're going to talk about different language strategies and different ways to help increase participation. So there's a variety of reasons why kids may not eat. Mealtime behaviors and food refusals may be caused by any of the following: oral motor skills, also known as chewing difficulties, swallowing difficulties, sensory preferences, their environment, and a vast number of other things like medical conditions that we're talking about today: IgE-mediated food allergies, EoE, FPIES, heart transplant, various different reasons. And I really wanted to talk about what are the specific EoE-associated feeding challenges or differences our patients see. And I want to talk a lot about this because there's a lot of talk in our field right now about pediatric feeding dysfunction versus APFED versus picky eaters. And so I'm going to dive deep into that a little bit more. But what we generally see with EoE and feeding challenges are the following. So if I have a child come in to see me for a feeding eval and their parent or their caregiver is reporting prolonged chewing without swallowing, that's an automatic red flag for me. If they use an excessive use of dips and sauces, that's something else that I might be like, something seems a little bit different. If they use a lot of liquids to help with swallowing. So these are the kids that will ask for refills of their drink during their meal, often once, twice, sometimes 3 times, and they seem to be using a lot of liquids to help them swallow each bite of food. Also, another thing that I've seen a lot with these kids who may not have been diagnosed with EoE is they're dipping their actual foods in water. I had a patient last week who submerged an entire waffle in their water glass and then took off little bits and pieces of the waffle before putting it in their mouth in order to swallow it. And then avoidance of just more difficult textures in general. So specifically meats, raw fruits and vegetables, and oftentimes carbohydrates. We call these foods scatter foods, and it's because when you take a bite, lots of times these bits and pieces kind of scatter all throughout the mouth and create oral residue that it's harder for the kids to use their tongue and their lips to help move the piece to make a cohesive bolus in order to swallow it. And then also we get reported really slow eating. So more than 30 minutes per mealtime to swallow these, to eat and to swallow these foods. And so it's because they're really relying on a lot of this prolonged chewing, this using these dips and sauces, using liquids to help them swallow. And it's just harder for them because they have this fear because they're in pain when they're trying to initiate a swallow. And then we see a lot of these mealtime battles because meal times are incredibly scary for a lot of these kids. It's also a lot of the parents are stressed because we just want to feed our kids, and the caregivers don't know what to feed them because one day something seems like it might be in their comfort zone to want to eat and swallow, and then the next day it's not. So let's really dive into what is picky eating versus pediatric feeding disorders or dysfunction versus ARFID. So picky eating is a picky eater is someone, often a child, sometimes adults, who consume an inadequate variety of foods due to the rejection of both familiar and unfamiliar foods. So they typically have strong preferences and may only eat a limited range of or a specific food for a period of time. And it's often a phase or a typical part of development. So think about your average toddler. Well, they ate mac and cheese yesterday, but today they're like, no, I am not eating that food. And so this is that realm of picky eating, or the adult that maybe you have in your friend group who's like, I just don't eat salads. I don't eat vegetables. They're not my thing. I don't like them. I don't eat them. So this is what we would kind of encompass as a picky eater. Now, pediatric feeding disorder is different. As defined by Feeding Matters, PFD is a chronic condition characterized by impaired oral intake that is not age appropriate. It lasts at least 3 months and is associated with medical, nutritional, feeding skill, or psychosocial dysfunction. And so it differs from picky eating as it inhibits growth, nutrition, or development, causing symptoms like coughing, gagging, vomiting, or severe food avoidance. So this is more intense, this is more severe than what we would say our picky eater would be. Now, avoidant restrictive food intake disorder is getting a lot of, I would say, highlights. We just had an awesome blog session about it. I'm sorry, not session, but blog report on it on the website that you can look at APFED. And it's actually an eating disorder characterized by extreme limiting of food type or amount, resulting in nutritional deficiencies, weight loss, or psychosocial impairment. Unlike anorexia or bulimia, ARFID is not driven by body image concerns. And it's often rooted in sensory sensitivities, lack of interest in eating, or fear of aversive consequences like choking or vomiting. And so I developed this visual because what I struggle with in my feeding community is that children and adults are generally categorized into one category. They're either a picky eater, they have RFED, or they have PFD. And with EoE, we can really be found in any of these categories, and we can identify it in a lot of these categories. And so when we think about EoE specifically, EoE, you can have a sudden onset of feeding issues. I can think about the hundreds of kids I've evaluated who out of nowhere come to me at age 8, 9, 10, 11, and they've all of a sudden had a food impaction and the food got stuck or it feels like a choking incident, and then they stop eating altogether. Now, mind you, that falls more into that RFID category versus the PFD because they didn't have feeding issues from birth. Now, mind you, working at a clinic like Children's Hospital of Colorado, where we had infants come in with issues with eating since birth, maybe they weren't tolerating breastfeeding, they weren't tolerating different food proteins that were in the formula, and they've had challenges literally since birth, that would fall under that pediatric feeding disorder category. And then we think about with EoE, a lot of us have an intense food avoidance. And mind you, it might be protective. Maybe I'm literally avoiding all meats because every time I eat it, it hurts to physically swallow. And so that can kind of fall under the trauma of ARFID, but it also can fall under the pediatric feeding disorder piece because it can fall under that frequently correlated with a GI issue, GERD, etc. And then thinking about preference of certain food textures. Well, I, for one, with EoE, definitely prefer crunchy, salty foods because crunchy, salty foods provide more sensory feedback to my brain, create more saliva, which actually makes it easier to chew and swallow. Where some people with EoE prefer wet, moist, and those types of prepared foods because they're easier to swallow in general. And then thinking about with EoE, we talked a little bit before about prolonged meal times with very slow eating, which is unrelated to oral motor skills. where someone with pediatric feeding disorder, they might have issues with oral motor and oral sensory chewing that would fall under the category of pediatric feeding disorder. However, with ARFID, you typically have no oral motor challenges. And so I wanted to kind of create a slide to show that with EoE, we're like these unicorns. And if you've ever heard me talk before, I always say that we're unicorns because we are different and we can fall into several different categories. And mealtimes can be stressful, and they're stressful in ARFID, they're stressful in pediatric feeding disorder. But if we have an average picky eater, it might not necessarily be as stressful. So it's just something to think about. And then with EoE and eating, this is often diagnosed by a gastroenterologist and multidisciplinary team. Picky eating is monitored generally by the pediatrician. ARFID is diagnosed by our dear, dear friends in psychology, and also within a multidisciplinary team. And then the pediatric feeding disorder is often diagnosed by a multidisciplinary team. So again, EoE, it's like these little pieces from all these categories can really affect eating. So as I've presented more and more on EoE and eating, I've really come to understand that it's stressful. So you get this diagnosis for your child. They likely have IgE-mediated food allergies on top of having food sensitivities, on top of having stomach aches, belly aches, vomiting, things that we don't know what are causing these adverse reactions to eating. And so we just want to feed our kids. And so the more data I've collected from these families, the more I've realized that we do short order cook for them. We do offer them highly preferred foods because we just desperately want them to eat. And so the more and more I've taken a step back and really tried to encourage and coach my families and caregivers, and also people I mentor in the community, other speech pathologists, occupational therapists, the importance of building a foundation for positive mealtime and food interactions. So what does that look like? The most important thing is to eat with your child. Whenever possible, eat with your child. Eating is a developmental skill, and this is how they learn about eating and about how they learn about new foods. We need to model eating the same foods and textures with them, and it's very important that we model the foods that are not your favorite in order to expose your child to these foods. I will never forget the dad that I've had in a session. He's like, I straight up am a picky eater. I don't eat vegetables. I don't like the way they look. I am not going to model those things with my child. And I'm like, you need to. It's so important because them modeling or you modeling the food and them seeing you eat the food, and even if you're hesitant and cautious about it, can only really encourage them to learn about the food because they're seeing it. You're their person. And so it's so important to eat these foods with your children. And just in general, I know that our lives are busy, and I know that it's easy to just pop your child at the table, give them their own foods and eat, and then maybe you and your partner eat later, or you by yourself eat later because you like to eat different foods. But they're not going to know or learn about the experiences with these foods if you don't expose them to them and they don't get to see from a good model. The other thing I like to bring up is Ellen Satter. She has created something called the Division of Responsibility. She has been in the feeding world for decades. She's a registered dietitian and therapist, family therapist. And what I like about it is that she really talks about what is our responsibility as a caregiver and what is the responsibility of our child. And the caregiver is in charge of what is being offered. And so for traditional meals, we need to offer preferred food that they can eat and fill up on and grow on. And it's really important that we don't sneak ingredients into preferred foods. I know that families, you often feel desperate. They don't eat their vegetables. They don't eat their fruit. I'm just going to bake it into some muffins. I'm just going to mix it into the meatloaf. We really need to ensure that our children trust us. And then as caregivers, it's so important that we don't sneak ingredients and try to trick them, especially with EoE. If you think about having EoE, and I think about myself because I've done several diet eliminations in order to try to figure out what my trigger foods are. And so it's confusing to children. One day we're saying, you can't eat this food. We're trying to see if it's safe for you. We're eliminating it from your diet. And then the next, we're like, oh, hey, you're on your medicine now. And we're going to try to start giving you this food and see if your body can tolerate it. And so think about that disassociation and that trust that they lose with foods because they don't know. it's safe one day. The next day, we're telling them they can eat it. We're on this medication. We're not on this medicine. We're taking it out. We're scoping them. We're seeing if it's a clean food, if it's a dirty food, if it's safe or not safe. So we really want to make sure that we have a really good trust and bond with our children and that we're not sneaking ingredients into preferred foods. And so just being honest and open about it. And so again, as caregivers, we're in charge of what's being bought at the grocery store. We're in charge of what's being cooked and we're in charge of what's being offered. And it's really recommended to rotate through preferred food options to avoid burnout. There's a big thing in feeding therapy called hyperfixation foods, also known as food jagging. And that's where kids go through a period of time eating a preferred food over and over and over again until all of a sudden they're burnt out and they don't want it at all anymore. And with diagnoses like EoE, it's really important that we keep all the variety we can and all the different forms and textures of these safe foods because sometimes their foods can be limited and the varies in the variety of food they can eat is limited. And then the child in this division of responsibility is in charge of what and how much they eat of the food we offer. And so there's no limitations to how much of a food we give. And there's no requirement to eat something else prior to getting more of the desired food. We do not reward with preferred foods because this gives the message that there are good foods and bad foods. We're going to talk more about this. The other thing that I noticed that with a lot of the families with EoE or any kind of chronic illness is that we have a tendency to let them graze because we are so anxious and we just want them to be fed. We just want them to eat, we want them to grow, and we want them to be healthy. And so the number one thing I talk about is eliminating all grazing to really help promote a typical hunger satiation pattern. All meals and snacks need to be offered on a schedule with 2 to 3 hours between these meals and snacks. We really want to avoid grazing on foods because this decreases appetite and it decreases participation at meals. It also decreases the volume of intake children eat at meals, even of their preferred foods. I swear I've had families flat out just not believe me, but I swear to you that this is true. Because if you think about like the diet mentality, and if you're having little bites of food throughout the day or grazing on your shake or grazing on your milk throughout the day, you're just literally just hitting the satiation. You're never actually truly hungry. And also, some gastroenterologists will tell you that if you are grazing, you're actually losing calories because your body's burning those calories instead of having the time to reset and absorb the calories at a mealtime. We do like to say that water is okay between meals and snacks because it doesn't necessarily affect appetite if it's consumed in small volumes. So, like earlier, I was talking about traditional meals versus learning meals. So, like, what are you talking about? So, a traditional meal is your everyday typical meal. This is your breakfast, your lunch, your dinner. These are the meals that we want to keep stress-free for everybody, focus on the calorie intake and preferred foods at these meals because again, fed is best. These learning meals is something that I like to dedicate 2 to 3 times a week to work on novel food introduction. And so I really like to stress using it as snack times because it's just a great time for food introduction, especially if you're following your traditional meals with the breakfast, lunch, and dinner, where they're getting their stress-free preferred foods at these meal times. And the learning meal at snack time can focus on exploring, learning about a novel, a less preferred food item, and not necessarily the calories or the volume of the intake. It's just for fun, it's just exploration. And during these learning meals or snack times, you can start with a very small amount of a preferred food because, again, in that division of responsibility, we are in charge of what is being offered to help promote that initial engagement. And then they can play or just interact, and you can model kissing and licking or, running a tractor through some of these new foods. Something that's more engaging and less scary than just jumping to taking a bite. Okay, so strategies to increase overall mealtime participation at both meal learning and mealtime, or in traditional meals. Sorry about that. Children thrive on predictability and routine. Let's face it, we all do. Having a clear beginning and ending to each meal is very important. So whether that's we all wash our hands at the beginning of the meal and we all wash our hands at the end of the meal, we all help set the table, we all help clear the table. Whatever that routine is, stick to it for each meal. And so the children know that this is when we're going to be eating and this is when we're finished with the meal. I also like to have you guys consider offering the same number of foods at each meal, not because I want your child to be rigid, but again, because it's predictable, it's part of the routine, and it eliminates any kind of surprises. If you have an anxious eater or if you have a child with EoE, they're not going to be like, I don't really love when caregivers are like, oh, here's another food, here's another food. Oh, you didn't eat that one, here's another one. It can just create a lot of anxiety around meal times. And I really always encourage offering at least one preferred food. And if dessert is a part of your routine, if you are a dessert family, all power to you, just serve it as this at the same time as the other foods. And because we don't want to reward with food. So like if you eat this, you get your dessert. That again puts foods into categories of good food, bad food. And then consider offering foods via family style, where the child can choose which food is plated first and how much. We're going to talk a little bit more about this. Language strategies. I really want to encourage people to use objective language, not subjective. Stop using yucky, yummy, good, bad, healthy food, not healthy, and replace with objective words based on our senses. The color, the shape, the texture, the temperature, the smell, the taste, the sound it makes when you bite it. This is something I created with an artist in 2021. And you can find it on Teachers Pay Teachers. If you email me at the end, you'll have my email. I'll just email it to you. But having them say like, oh, is this food squishy? Is this food bitter? Is this food wet? Is this food crunchy? It helps them use the appropriate language to describe a food. Oh, it looks like squishy, sticky foods are kind of tricky for you. Let's see if we can try this food in a crunchy, hard way. And then this is where Katie came in and helped give me some ideas for regulation. It's very important to be regulated. And if they're not, it's important that maybe you get an OT referral to help with your child's regulation. We really want everyone to be regulated to participate in the mealtime. And you can support regulation with purposeful activities before a meal. Focus on proprioceptive, vestibular, tactile inputs. You can work on heavy work activities like pushing, pulling, lifting, or carrying things before the mealtime. You can work on vestibular things like swinging, jumping, rolling. And then you can work on tactile activities like sensory bins, water play, or messy play. And this can actually involve having them help prepare the mealtime. And this is something else I asked for her to help me make because I really feel like seating is so important. Our digestive tract is so sensitive, and it's really important that there's proper back support, foot support, and head and neck support in order for kids to be able to chew appropriately, to digest appropriately. And then thinking about the height of the table, I'll never forget because I started doing telehealth that a parent was like, well, they're not really using their utensils and they just grab whatever's like in front of them. And the table was like up here and the little child was just using their hand, grabbing whatever they could because they couldn't see because they didn't have the appropriate seat. And then finding different things like I'm short, I'm 5'1", so I love having something at my feet to help me stabilize, even as an adult. It's why I avoid bar stools because it's helpful to help me have more of that sensory input, but also to help me with chewing and swallowing. Okay, so just increasing participation, different tools of the trade. Again, we really want to promote independence and allow them to have control of what they can be in control of. So shakeable toppings. This is something that I add all the time. It can be salt, it can be sprinkles, it can be sesame seeds, it can be a cheese shaker. And oftentimes it'll be like, oh, you can have one or two shakes on your food. Or, oh, you're learning about strawberries today. You can add sprinkles if you want. You can add one shake or two sprinkles or round sprinkles or star sprinkles. And then using things like cookie cutters or kid-safe knives, different types of food picks. I'm going to show you guys some examples. A food chopper to change the texture, but also letting the child do it. So if you're giving them chicken and they're like, oh, that looks scary, like, oh, well, you can use your knife to cut it into a shape or size you want, or a food chopper to dice it up into teeny tiny little balls. And different things like the Talk Tools Itsy rings. So these salt and pepper shakers, I love. Fair warning, they come out real fast, but it's a magic wand at meal times. I like these little individual salt and pepper shakers because you just push it once and it gives a measured amount of salt or pepper or any seasoning. I have a kid who has garlic salt in his. Some of these fun Japanese knives, some of these other knives, These cute little fruit picks have really evolved over the years since I started doing feeding therapy. I love them because the child can pick the exact size of the new food they're learning about and put it exactly where they feel comfortable in their mouth, whether it's the front, the side, avoiding their tongue, on their teeth, right on their tongue. And they feel more in control versus having a larger utensil where if they take too big of a bite, it might fall and then it feels scary because they don't know where it's going to fall in their mouth. Little cocktail forks, these little fruit forks, if you Google them, come in princesses, which is pretty cool, a food chopper. And then these itsy rings are something that I like for kids because you can use them for a variety of reasons. I'll put a little piece of a soft solid or a new food in that little ring so they can chew on it and just get a tiny taste while they're getting some of that sensory feedback and biofeedback from chewing. Okay, some other tools of the trade. Change the presentation, the power of choice, using different cups. A lot of these kids have to use a supplement to help with their nutrition and growth. Or we really would like them to drink a smoothie, or we would like them to drink more water. I like introducing all different types of cups and giving them the choice. This measure and pour cup I love. I learned about it in a cooking class. There's a 1 ounce version and there's a 4 ounce version. Kids love to track how much. So if you're working on them drinking a nutritional supplement, you can say like, okay, we're going to work on 10 mLs today. Oh, tomorrow we're going to work on 30 mLs. Oh, we're going to go up by 5 mLs. And then if you have a new little one who's learning how to kind of get off breastfeeding or their bottle, this Talk Tools cup I love because you can actually press it and it preloads the straw for you. So it teaches straw drinking, which I just think is so cool and amazing. And then IKEA, and you can get these on Amazon, have these teeny tiny little fork or little spoons, goblets, or I'm sorry, spoons, listen to me, cups, little goblets or little cups. And I say, oh, are you gonna, you can pick between your blue or your green cup to drink out of today. Which one for your mealtime? Using different plates. Again, this is just something to kind of entice. If you're having a hard day, we all have hard days. Would you like to use your pirate plate and eat around in a game plate? Would you like to use the animal plate? Truth be told, I take out the spinner because it's a distraction. So I'll just put a little bite of food in each section, be like, ooh, are you going to eat the beaver bite first or the monkey? And then using just silicone ice cube trays, I love using this and I'll just put a small bite of food in each section and let them have the choice between which plate they want to use that day. Using cookie cutters that are child friendly to help them change the shape of a food, using uncrustable cutters for my sensory friends, myself included. Like, I cannot eat a peanut butter and jelly if jelly gets on my hands. I'm 42 years old. I do not like the feeling. You can use an uncrustable cutter so their hands don't get as messy versus a traditional sandwich. And then cooking. I think a lot of us are busy, a lot of us are overwhelmed, and a lot of us are anxious. The society we live in, unfortunately, that's what we're living in right now. But having these kids help participate in cooking is massive. It's crucial for them because it helps them interact with new foods by helping prepare them. You can encourage them by smelling, tasting different ingredients as they help cook. You can have them help pick out recipes, and then you can make recipes into visuals to make it easier for them to follow and lead if they want to do some independent cooking, like my friend is doing on the left here with the KitchenAid. And then what I like to do if there's a recipe that actually, regardless of the recipe, I'll have them kind of rate it. So was it a 5 out of 5? Was this a recipe you'd like to make again? Was it a 4 out of 5? Do you think maybe you'd make it again? Was it a 3? And you're like, meh, I'd prefer not to make it again. It's just something to help keep track, create ownership, and have them feel like that they are part of the mealtime. The other thing is creating jobs, having them set the table, choosing the dishes. I always joke that I have fancy dishes because I'm feeling like I had a rough day, so I want to eat from my fancy dishes today. And then I have my basic dishes. So, like, are we princess and princess eating like, are we going to be eating from our fancy dishes today, or are we going to eat from like our regular dishes? Having them choose the cups, having them help serve themselves, letting them cut their own bites, having them clear their plate, different jobs during the mealtime that really help them be more invested, having them wash the table. Okay, this is a huge one with EoE in general, altering the texture. I think people get so stuck on a food is a food is a food, and you have to eat it this way. Well, it's just not necessarily true. This is an outdated picture, and I apologize, but this is an example of apple. So you can eat an apple in so many different forms, and it's still an apple. None of these forms have any added sugars to them. In this picture, it shows freeze-dried apples. It shows dehydrated apple. Oh, I'm sorry, it doesn't show the dried or dehydrated. I didn't have that picture, but it shows fresh apples. It shows applesauce. It shows that apples, I have stewed apples in the corner, and I have apples that are cut in different shapes. Just changing the way that the texture is, it still counts as eating the food. So if you, me as a grown adult, are going to say, here, how would you like to eat the apple? I would 1,000% always pick eating it in matchsticks. It's easier for me to manage because it's a scatter food. I can take small bites, I can place it on the side, I can grind it with my molars and swallow it more easily. I'm not going to pick an apple with skin in it because it's harder for me, even when I do not have inflammation, to chew and swallow it. I can still feel it in my esophagus. And then another thing that we can do with EoE is add a preferred carrier food or helper food. So carrier or helper foods are a highly preferred food that can change the texture and or taste or both to a new food to make it easier to accept and or chew or swallow. So here's a cutie patootie using two saltine crackers to add to her meat to make it easier because the crunch creates more saliva and more sensory feedback to her brain, which helps create a more cohesive bolus, which is a fancy word for mixing the food with the saliva to make it easier to lubricate as she's swallowing it down. Now, this little guy, the parents came with me, he has EoE, and they were like, he will not eat tacos. Taco Tuesday is a thing in our house. It has been a thing for decades, and we want him to eat it. And they were only offering him it in a soft shell. Well, the soft shell with the combination of a ground meat with shredded lettuce was too hard for him to manipulate and swallow. And so I said, let's try a crunchy shell where he can have more actual natural lubrication as he chews and swallows because the crunch and the salt from the crunch provided more saliva. And then, just tried and true ketchup, but any kind of dip or sauce. I'm just a ketchup fan, so this picture was cute, so I included it. But it can be dips and sauces. So Marsha Duncline is another feeding specialist in our field who's been around for decades. Decades. She's an occupational therapist. And this chart I really like using because I feel like parents and caregivers get stuck on taking a bite. A bite is a bite is a bite. When you have EoE and you are not sure about a new food, please do not intimidate your child. Be like, well, that wasn't a bite. Because if they took the teeniest, tiniest mouse bite, to them, that's a huge feat. And it counts. It's a bite. And you can use a chart like this to slowly increase their comfort level with different bite sizes. And you can also encourage the child to pretend to be that animal as they eat. Like, oh, are you going to be an elephant or a horse as you take this bite? Which one? Sometimes I actually like to take the food that we're working on and I will cut up like a piece of chicken and put it on a laminated sheet of this and work as we build up in size and comfort level with the food. Okay, so systematic desensitization is a very familiar term in feeding therapy. And some ways to increase participation is using this. And so I like to use this picture and incorporate it because there's all different types of people in the world. But if you think about it, are you or your child someone that likes to touch the water before you jump in and see and kind of see, is it warm? Is it cool? Is it hot? Or do you like to jump right in? So with systematic desensitization, these are the kids or the people, the adults that really like to slowly build up to learning about a new food. And so how can we help support that? We can use something like this, where we can encourage them to smell a food, touch a food, tap it on our teeth, hide it in the cave, take it out, kiss it, lick it, do teeth marks. And there's a simple version on the bottom. So it's a slow hierarchy-based program that helps your child slowly interact with a new food until they become comfortable to take a bite. And there's different ways you can learn about foods besides just taking a bite. And then just some other helpful tips and tricks. So generally in feeding therapy, drinks are always offered at the end of the meal. We do this because it helps avoid filling up on liquids before foods. I always like to include the marble effect. So for example, if I have this mason jar and it's full of marbles, and let's say, for example, this was full of water first and I added a marble, the liquid would splash and hit the upper esophageal sphincter and make you think that you're full prematurely. Versus if we're eating our food first and then I slowly poured liquid into it, it'll seep in between all the nooks and crevices and not necessarily make us feel full more quickly. And so I'll explain that to kids and to parents. And we really like to try to keep the beverages at the end of the mealtime so they don't prematurely become full. However, if there is active esophageal inflammation, think about some of the earlier slides where it's really important to allow a liquid wash or a sip of a drink after every few bites to help them clear oral and esophageal residue. And then, when possible, really, really, really encourage children to serve themselves. I touched on this very briefly. And we talked about language strategies, but provide you can statements where you can say, okay, here's family style. We have 3 or 4 foods on the table. You can start with the chicken or the apple. Which one would you like to start with today? You can have 1 scoop or 2 scoops of the mashed potatoes. Which one? You can have 2 pieces of chicken or 4 pieces of chicken. And if they're like, holy Toledo, no, thank you, you can say you can take 3 mouse bites or 3 elephant bites, or you can take 3 teeny tiny mouse bites of chicken or 4 teeny tiny mouse bites of chicken to put on your plate. Using those types of strategies versus saying, do you want chicken next? Because they're going to say no. This slide is something that you guys can read over on yourself or by yourselves, but it's something like when to seek help. So there's different types of things that if these strategies aren't helpful on their own, that it might be helpful to seek help from a speech pathologist or an occupational therapist or from one of our fabulous behavioral therapists and or psychologists and social workers. And so I wanted to include this last slide before we get into questions because I really want to encourage families that feeding therapy can really change the mealtime climate. And so if you're struggling in any of the areas here, or if you're struggling with getting your child to come to the table, those types of things, please seek out help. There are a lot of us out there, and EoE has been around now that there's been people like myself and other people, other speech pathologists and occupational therapists who specialize in this that have really mentored and really helped educate different providers and hopefully in your community to help your child be as successful as they can be and to help you. And feeding therapy can really help establish healthy mealtime routines and boundaries. It can really help you build overall confidence. And I think this is something that I wish I had when I was younger. I was scared. I had IgE mediated food allergies and I had food sensitivities. I didn't know if I took a bite of a food, if I was going to require an EpiPen, or if I would be vomiting for several hours or have extreme stomach pain. And so in therapy, we can help you navigate, use these strategies and a bunch of other strategies that I didn't share today with trying new foods. We can help. I love having my teenagers where we go to a restaurant and help them order at a restaurant. I'm avoiding dairy and wheat, or I have an IgE mediated food allergy to this, and I'd like to order XYZ. Are these ingredients in this food? Helping them navigate special diets and then just having them help navigate food allergies. I have some really little kids where I really start very young in therapy. And when we start and sit down, I say like, oh, do you have any food allergies? And I have them help start reciting what their food allergies are so they can build confidence and awareness and parents don't feel like that all of it is just on them. I also really like to encourage use of compensatory strategies and have kids start really leaning into dips and sauces and using a liquid wash if it's appropriate, or using some of these crunchy carrier foods. Like you are not going to see me eat a soft taco, and I have no inflammation. While I have required some dilations because my EoE wasn't diagnosed until later, but it's easier for me to pair some of meats with something crunchy versus eating it with something soft like on a hamburger bun. And then help with acceptance of nutritional supplements. So there's all of these lovely supplements on the market now. That wasn't the case when I was younger, but some of them taste better than others. And some of them, unfortunately, our patients require or your child requires that they need. And so really helping them learn to accept those supplements in a safe manner without forcing, without a lot of pressure, in a very systematic way. help with teaching medicine acceptance and pill swallowing. This is something that's really relevant, especially with the string test that's becoming more and more readily available in different areas in the country and the world. This is something that a lot of speech pathologists and occupational therapists can help is teach your child how to swallow pills and then also help guide or wean from enteral nutrition or tube feedings. And so we're here to help. APFED has this great specialist finder, and I did check it out earlier today. There are different feeding specialists on there. Feeding Matters also does have a great provider directory on that as well. And then this is my website and my email if you'd like any of the visuals. I can't thank you guys enough for joining us today, and I'm hoping that you guys have some questions.
Thank you so much, Holly. It's always interesting to hear all the different tips and techniques that you have to be able to help people. Well, as Holly mentioned, we're now going to open it up for questions. So you'll see on your screen, there's a Q&A box. Go ahead and open that up and you can type in your questions. So we're looking forward to having a follow-up discussion here.
Perfect.
Alrighty, so we've got some questions from people that are asking about how to manage after a traumatic experience with food. One person, an example, their child had a traumatic appointment trying to get a feeding tube. And so they're just trying to look for ways to be able to cope and get support with eating after that experience.
So after having a traumatic experience, and this is something that unfortunately happens a lot in healthcare or with EoE, you might choke on something or you might have to go to the ED with a food impaction or the food goes down the wrong way, those types of things. And so I really feel like it's important to lean on our psychological and social work help in these instances and also just go slow. That systematic desensitization piece in feeding therapy is so important because they might have had this event and all preferred foods seem like there's no way, Jose. Like, I have no interest in that anymore. They are no longer deemed safe. I am not interested in those foods. And so just meeting your child where they're at. Are they willing to engage in sensory play with the food? Are they willing to use cookie cutters and pretend like they have their own bakery and roll out some dough and cook it and bake it? Or I'm sorry, cut it and bake it? Are they willing to maybe help you mix something at a mealtime? Very, very slow steps. And then you, as the caregiver and or the therapist, you model different interactions. So for example, I have a patient with EoE and RFID who just had a significant food impaction and they stopped eating everything and they wouldn't even drink liquids. They had a temporary NG placed. And so what we did together was we started making smoothies and I would just model like licking this or drip it on purpose, be like, oh, that's pretty sweet. And like pour it into here, or I got out syringes and I'd spray it like out this way and we played with it. And eventually she started just tasting it and then licking it and then taking sips. And then we did calculated little, like with like these little measuring cups that I happen to have the two sizes here because I do virtual feeding therapy, where I'm like, oh, let's see if we could just do like a 5 ml sip. Or with a little syringe, you can just lick off a tiny bit at a time. And you build up their comfort, their confidence level very slowly. And then from that texture, I go to dissolvable or meltable solids because they melt in your mouth and turn into a liquid. And then from there, we go up and up and up in the chain. So that's a really good question. And it's something that a feeding specialist can absolutely help with, or your psychological support too.
Does helping people with eating differ by age? We're getting some questions in here about how do you help an older child? I've got an 8 and a 10-year-old that want to try foods, or I've got a teen that was hospitalized and now they're only wanting to eat elemental formula and a few safe foods. Like, so what differs between the young child that wants to pretend they're baking food, the 8 and 10-year-olds, and the teens?
This is a phenomenal question. So now that I am strictly doing private practice, I see infants all the way through geriatrics. I would say I have an equal split of adults actually with EoE that are newly diagnosed who have had an event that they're petrified to eat. I have a lot of teenagers and I have a lot of kids and infants. So I guess it's not an equal split, but I have all over the age. And it's very important to think about where they are cognitive level. And so if some of these visuals are inappropriate because you have a teenager, do not use them. However, you can encourage them by interacting with different foods, by having them help prepare something in the kitchen, by having them help find a recipe online. If they are allowed social media, which I am so ancient that I don't have it really anymore, but like I have a lot of patients who'll say, well, like I found a recipe on TikTok and I'm interested in this and I want to make this. And I'm like, okay, let's make this food. It's involving them in whatever step they might be interested in. It might just be grocery shopping. You literally bring them to the store if it's not overwhelming and say, these are all things in your category that are safe for you that we can learn and, and that we can learn about. And it might be them just grocery shopping at first. In feeding therapy, it is the job of the feeding specialist to really individualize the plan appropriate for their cognitive level, their medical where the status that they're at, and their comfort level. And so I have a patient that I play what is the game we play? I think it's called Spit. It's like a card game while we're doing it because their therapist encouraged us to do something that can help them just slightly disassociate from the stress level. And as we're doing that, like we will casually snack on something that once was a preferred food because they had a scary event and then they were recommended to go elemental. And so it definitely varies, and there is a model of care for every age, and it does differ. And so I just gave you guys a really broad amount, so I apologize that I can't like specifically dive deeper into each individual age group, but there's model based, there's play based, there's cooking, and then there's more of just having really fostering that independence with the teens and tween age group.
You have mentioned that you do virtual feeding therapy and people have questions.
Oh, sure.
So specifically, they've tried feeding therapy locally, but it feels like it's outside of the scope of that individual person in their experience. So how does virtual feeding therapy work and can it be offered across state lines?
So that's a great question. So I have 9 different state licenses. Don't recommend it, but it's really important to me to help people get the appropriate care. And so there's two ways we can go about this. If there is an EoE specialist on the APFED specialist finder that specializes in EoE and has licensure in your state, they are allowed to treat you and they can provide you with a super bill or if they take insurance and they can see you virtually. In 2012, I started doing feeding therapy via telehealth. Long before the pandemic, through Children's Hospital of Colorado, we actually did a research study because I was going to be like, I didn't really think that it was going to be a viable method of therapy, and my hypothesis was wrong. This is why we do research, and it's blown up, and it actually proved that it's actually more helpful than going to a clinic because you're in the patient's home environment. So that being said, you can look that up at Gastroenterology Journal. Um, and then if, let's say, for example, I don't have licensure in your state or the therapist you choose to work with doesn't have licensure in your state, you can pair it with their feeding specialist and they do the billing and you offer modeling or coaching to help them feel more comfortable and in order to provide the best therapy possible that is appropriate for your child with an EGID. And it is really important because it is a very different style of feeding therapy. Yes, it blends a lot of different approaches. However, if they're not familiar or comfortable with it, you have to be cautionary because I don't want people to put too much pressure on these kids because it has been traumatic or it can be scary. And you have to really go at their own rate and in their own level of comfort and be supportive at the same time. So it's a good question.
Continuing to get more questions from from parents with teenagers
Yes.
and different questions there. Could you spend just a couple minutes talking about like kind of the approach for teens?
Yes. So the teens, um, I really for teens, I have to be honest, it's probably my favorite age group to work with because I was that teen. I felt like I had a lot of anger, I was on a very strict food elimination diet. They didn't know I had EoE because I'm 42 and there was no such thing when I was a teenager. And it was very isolating, and so I can relate to them on many levels. But what I like to do with that is I have them come up with a list of foods. So there certain things that you wish were easier for you to eat, especially in X setting, like with your soccer team, with your friends at school, at a birthday party? Are there places you want to travel internationally? Let's come up with that list. And then from that list, if there are specifically on a food elimination diet, then I say these are the ways that we can make it safe for you and in the texture that is desired. I talk a lot about textures. I talk about that slide where I had that plate with the apples. Like, if you really want to eat pizza, to me, pizza is a hard food. It's multiple different textures. You can see my face. It's really tricky. It's hard to manage. It's hard to coordinate a swallow, but it is everywhere. Pizza is everywhere. It is the most like socially, I don't know, food that's in for years I couldn't have wheat or dairy. And I was like, why is there pizza everywhere? And so instead, like, how do we slowly build up to that texture? I have a patient right now that we're working on it with EoE. He's 17. His girlfriend loves pizza. He's desperate to take his girlfriend on a pizza date. So right now we are eating like a safe gluten-free cracker with a teeny tiny bit of sauce and two shreds of a safe cheese that he makes himself in a toaster oven. It has taken us 3 months to get to that stage, and he is proud. His girlfriend's proud of him too. And so you have to really find where they are, meet them there, and slowly scaffold off of that and build off of that. I like to take them grocery shopping. I like to have them come up with a list of foods that they'd be willing to learn about. I love to pull in my dietitian friends and say like, "Hey, where are we nutritionally deficit? Like what foods do we need to be working on?" And then I will sit with them and pull up the internet and be like, "Oh, have you ever heard of dragon fruit? This is what this looks like. This is a fruit that you've probably never looked at. Maybe that's something we can learn about. What textures do you like? Oh, okay. So you are a crunchy, kind of wet textured person. Maybe you would like apples, and then apples, if you like that crunch, then maybe you might like carrots because they're in the same food category. That's called food chaining, where you take a preferred food in their texture and you slightly build off of that in very, very, very specific ways until you can kind of breach from that preferred safe food. And to me, that's huge. And versus like saying, "Hey, Jen, like you like apples. Guess what? Now we're going to go to blueberry." Well, guess what, lady? That is like way too many changes in one thing. The likelihood of you enjoying that texture if you only eat apples is very small. You can learn to like it, but I'm not going to just dive into that. It's a very different group of textures and foods. So there's so many things at play that you have to think about, especially for these teens, and their brains are going probably as fast as I'm speaking right now. But those are really good questions. And again, I'm happy to help, happy to coach, happy to do parent coaching. That doesn't require a license in any state. But really just finding your people, I think makes a huge difference. The APFED conference coming up, huge wave for teens. If there's a serious fun camp by you, they have EoE weeks paired with GI. It's a free camp. They cook for free for their food allergens. Have them meet other people with EoE. It is such an isolating diagnosis. And once you meet someone else that's going through it, it's just like you're like, oh, I'm not the only one. Keep saying we're unicorns. We feel like a unicorn, but guess what? There's other unicorns out there.
Backing it up a little bit, if someone is newly diagnosed,
Mhm.
what are things that you can do as a caregiver to be able to help support their journey?
The number one thing is to have that predictable mealtime routine. I'm assuming your journey in terms of eating, is to have that predictable mealtime routine and structure so they know what to expect. There's no surprises. They're already enduring different surprises with if we don't know what their food triggers are, if their disease isn't under control. We want to eliminate all the surprises possible. And so if they can rely on like we eat at this time of day and mom has three or four things or dad or caregiver has three or four things offered, I'm always going to have one thing that is highly preferable on my plate. And I always wash my hands at the beginning and at the end. Anything that we can have that's predictable is really important with a diagnosis that unfortunately is unpredictable. Um, and I think that's something that I still really like, like I eat at a table. I don't eat in front of the TV. I have, use utensils. Like there's certain things that we can control. If I go out to a restaurant or if I go to Jen's house for dinner, There's a plate, there's utensils. I can wash my hands before I can wash my hands at the end. There's things that I can do that have the safety net that make me feel like that it's predictable, I'm safe, and it's routine.
What do you recommend if someone gets to the point where they are refusing to eat any food?
So if they're at a point where they're refusing to eat any food, we need to really know why. What is going on with their disease? Have they been evaluated recently? Do they have psychological support? Do they have someone that they can talk about these feelings with or someone they can relate to? I think that's the number one thing first. And honestly, depending on the age, if it's a teenager who's had I had a tube. So if it's someone that's had a tube, trying to figure out what they do feel comfortable with. And that might literally be reading a cookbook. It might be looking at a food and wine magazine. It might be pretend play in a kitchen. There are things that I avoided for years because I was in a situation in feeding therapy that was a lot of pressure and a lot of force feeding that my parents did not know about. And it's evolved. Feeding therapy's evolved. It's not like this anymore. However, I didn't want to talk about foods. I didn't want to be in the room with foods. I didn't want to go to restaurants. I didn't want to go to any holidays. I didn't want anything to do. If there was a TV show or a book about food, nope, avoid, 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 avoid. And so I had a therapist who was lovely that did not involve food, that we talked about my feelings. Like, why is every holiday surround meal times? Why does everybody get to eat cake and I can't? Why, like when it's someone's birthday, do kids bring in stuff at school and I can't have it? So just really getting to the root of that and then also helping get the disease under control and talking with your medical team about quality of life. I feel like there's some teams that do beautifully at this, and there's some providers that do beautifully at this. But what is going to improve quality of life for this child? Is it doing a medication over food elimination? Is it seeing a team all together so we can look at the psychosocial, their health, their disease, their allergies, their what can we do to support this child or teen or adult in order to make sure that we are at a stage where their quality of life is getting protected. I say protected because I feel like there's certain providers that it's not even just providers, even for me as an adult, there's certain people that don't think about you as a whole. And you're like, no, like they're depressed. This is affecting, they don't want to go out. They don't want to meet up with friends. Everything has to do with food. They're avoiding it in all scenarios. So you have to really think about how can we protect them and provide better quality of life in order to get that foundation so they are able to talk about, interact with, eat foods.
I think this dovetails nicely into kind of a theme and some of the questions that have been coming in, and something you and I were talking about earlier is when do you work with a feeding therapist, a dietitian, or even a psychologist? There's different
Yeah,
questions coming in here about that. And so I think it'd be interesting to kind of, as we wrap up here today, think about that. Feeding therapist, dietitian, psychologist.
absolutely. And it's such an important question. And if you're in an area that has a robust multidisciplinary team, you will have access to all of these in one visit, which is great. Now that I live in a very rural state, there is not a multidisciplinary team where I live, and it is harder, and you have to drive to care. And unless if you can afford to fly to a multidisciplinary clinic. And so it's really hard to kind of pick and choose. And so if it's an issue that your patient or if your child is not growing and they're not thriving, it's really important to see why. What's the etiology? What is their disease looking like? And if that's the case and your child is, let's say they're falling more in the ARFID group where they are scared. They've had a allergic reaction to a food. They've had a food impaction. They've had a really traumatic response where they ended up in the emergency room. It might be worth your time to actually work with a psychologist first or a social worker that really specializes in EoE to help them get to a baseline where their mental health is supported and they are supported. And then once that's established, then you can introduce a feeding specialist to say like, hey, let's work on adding some of these foods back in. Now, mind you, if you have a patient, or I'm sorry, if your child or if you have a patient is not growing and not thriving, we really need a dietitian support, often paired with their gastroenterologist, because it might be time that we talk about enteral feeding, which is a fancy word for a G tube, or we talk about supplements. And speech pathologists and occupational therapists can't do that. We don't look at the micronutrients of what they need in order to grow and thrive. So that's a very quick version of that. But again, I included my email on the slide. Jen is free to blast it out. Pickyeaters.co is my site, and I will get back to you as quickly as I can to help you kind of dive into which one would be the best route for your child.
Thank you so much for answering so many of the questions. I know we did not get to every single question that came in today, but we tried to touch on at least the topics that are coming in through the different questions today. So, as Holly shared, feel free to check out her website to be able to learn more information and connect with her. We'll post this recording and make it accessible to people to be able to continue learning. So, thank you again.
Thank you, everybody, and thank you for supporting children. Sorry.
Wonderful. All righty. So we also want to make sure we're taking time today to be able to thank our education partners for supporting this webinar. That includes AstraZeneca, GSK, Sanofi, Regeneron, and Takeda. To continue learning more about eosinophil-associated diseases, in addition to our webinar series, we also have a podcast, which Holly is a co-host of. So I encourage you to check that out. Our most recent episode featured a patient advocate living with EoE. Her name is Jessica. You can check it out on Audible, on Apple Podcast, on Spotify, and also on APFED's website at apfed.org/podcast. You can take a listen to learn more about her experiences with EoE and life transitions. We also have mentioned a couple times today about our annual patient education conference. So this summer, we're going to Denver, Colorado. We hope you'll join us there. Registration opened earlier this week. You can check it out at apfed.org/conference. So we will have a hybrid conference once again this year. You can join us in person in Denver, or you can join us online. There's advantages to both. Alrighty. Another part of living and helping other people with eosinophil-associated diseases is sharing your story. It can make such a difference. If you are at all considering being able to do that, please visit apfed.org/share your story. It can help inspire others, it can help connect with people, and it can help raise awareness. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again to everyone for joining us and to Holly for a great presentation. If you have a question that didn't get answered today, please feel free to email mail@apfed.org. I hope everyone has a great afternoon.
Hi, thank you.